And I'm trying to do a lecture on what's about prosthetic soft tissue development. And it's a new theme for me, so I said, try America first. And let's see how it goes. So I'm coming from Heidelberg, Germany. If you come visit, it's a very old university, 700 years old. It was the only city which wasn't bombed in the Second World War, and it's a big tradition. We have a big density of Nobel Prize winners per capita. The Bunsen burner was invented there. Mr. Bunsen for the dentist, very interesting. This is my office and my teaching facility. It used to be the Hunters Lodge of the city of Heidelberg. Now, I'm teaching in the US at different university in perio, in endodontics, but it's usually always about flap design, which is not going to be my theme today. And let's see how this is taking us. Now, soft tissue management was in my focus for many, many years. I started with flap design, and then we turned to the prosthetics. And I realized that you have to think twice. One is for the bone. When we developed the sites in the early 2000s, we used to look at blocks, at sinus lift, at GBR, and augmentation, but we realized, like we saw before in Maurice's lecture, that the soft tissue really makes the difference. And the long-term follow-up. And I will look at the soft tissue development and the long-term follow-up in patients treated by doctors which have thick biotype and patients which have thin biotype. What's the follow-up of recession covering procedures in patients with thin follow-up, especially in Asia? But let's go to the actual theme. So what we see here is how we think today about development, prosthetic development. Prosthetic development, especially when we have delayed implant sites. In immediate implant placement, we can preserve, but when we have to develop, especially in patients which have a long papilla, where the contact point is incisal, near the incisal edge, when it's more than 40% of the interproximal space, can we develop it in single implant placement, and also in multiple implant placement? So when we talk about soft tissue with surgery, we look at soft tissue management with surgery, with implant positioning, and then with pros. When we talk about surgeries, how do we manage the flap design for bone augmentation to maintain it, to maintain the blood supply? We talk about soft tissue management in the aesthetic zone, managing different flap designs, which we describe, many of them in the literature. Implant positioning can also influence the gingival margin, the interproximal papilla. We know today that implant placed in the right position can influence the gingival margin, can lead to recessions. But what's the ultimate now that we can play with the soft tissue and develop and protect recession by prosthetic soft tissue development? And I'm going to focus on this part. So it's a long journey when we talk about soft tissue, but to have the ultimate aspect, to develop a good, appealing aesthetic design, we can talk about soft tissue. Now, when we looked in the year 2000 in the literature, every implant used to come with a recession of 1 millimeter. I saw Dr. Grunder here in the room, a lot of respect. This is a study done in the US, so 1 millimeter recession from the time of abutment connection. Why? Then we looked here in Europe, also studied by Dr. Grunder. We looked at also 0.6 millimeters in the early 2000s. Then we look in the newer literature and we see that usually what we promise to the patient that the implant crown will be similar to the natural tooth, it's not really true, or it wasn't true in those days. So let's see what's easy, what is very predictable, is preserving. That's what we see in many, many meetings. You extract the tooth, you place an implant immediately, especially in patients which have a thick biotype, and then you restore it. You restore it so you can maintain everything. It becomes difficult when we go to the next step and we have to go for delayed implant placement or early implant placement. In this case, for example, we place the implant, we can maintain the interproximal soft tissue, and then with the prosthetics, we can use temporary crowns. But if we don't have any deficiency, we can maintain this tissue, and this is a very predictable way and very much published on in the literature. The crowns, the pressure of the interproximal space, that's something which we learned, and we can achieve good results. Now we will go back and see what's the long-term follow-up of these cases when we develop soft tissue. This is predictable. When we look in the literature, immediate implant placement with immediate restoration is predictable, and we have very good results. Now, when we go into 2009 now in the newer literature, we see that the interproximal papilla, which used to be our worry, we can say it's predictable. If we have the interproximal bone, we know the Tarnow rule, we know the publication of Stephen Chu, that's predictable. Problematic seems to be the midfacial. What we have today is recession around implants. We have to take care of that. We have thinning of the tissue around the implants. And if that's delayed, it's much more predictable. Now, when we look, we measured in 2007, we tried to maintain this soft tissue also in immediate restorations. So, immediate implant, even in the cases where the interproximal height of bone was resorbed. So when we look in cases like this, when you don't have interproximal bone, when you don't have a contact point, this becomes very difficult to achieve, because we know that the distance from the interproximal height of bone to the future contact point plays a big difference. So these cases, like Maurice mentioned before, you don't want to touch the interproximal space with your blade because you're going to lose that. So in these cases, maintaining or preserving the soft tissue is absolutely necessary. We can use it with the Maryland Bridge using Frank Spear's design. We can use different techniques. So 10 years ago, when we measured this, we realized that even in the cases where the interproximal bone is not there, we can maintain the soft tissue over time. Periodontically, we maintain a long junctional epithelium, which could be a problem. But when we look at the gingival margin from the buccal aspect in 2007, that's 10 years ago, was the publication which we did. The first cases were done in 2003, and now we can look back at 13, 14 years follow-up. We realize that even if we don't have an interproximal bone, even if we don't have a contact point in cases with diastema, we can achieve good results. So we were looking at 7-year follow-up. So immediate implant and immediate restoration. It becomes difficult when we have late restoration, when we have to develop the interproximal soft tissue and to protect the midfacial from recession. Now, when we look at this publication, you can see there is a very big difference if you restore an implant immediately, like we saw, with soft tissue management, with connective tissue graft, different procedures, or if you restore late. When you restore late, the midfacial recession is 2.5 to 3 times higher for the delayed restoration. However, we want to make these cases also work. So we developed an algorithm of the developing of these soft tissue techniques. Now, this is what we want to avoid. Now, when we want to restore or repair these cases, how do we know if this is a surgical problem? Let's make a test. Let's look at the second picture from the right or from your left. Which specialist would you refer this case to? Is it a periodontist? Is it a prosthodontist? It's not an endodontist, that's for sure, but okay? Now, we don't even know when we have this problem, and this is today, 16% of these cases, 60% of the cases implant placed have this kind of complications. If we look in Germany, 1.2 million implants, it means 200,000 complications a year, cumulative. How to avoid it, we suppose we know. But when this is happening, we have to fix it. But today, we don't even know where to refer, because we have to develop a system. And the system today is heuristic decisions. Let's see why this problem happens. So delayed, which is the complicated part, is here. After extraction, you have a collapse of the gingival margin. You have a loss of height of soft tissue. Now, this has to be recovered. Single tooth, can you do the bone regeneration vertically? So we have to regenerate the midfacial soft tissue and the interproximal papilla. Now, is that predictable? What's happened over the years? In a single tooth environment, we know that we have the Sharpei fibers which maintain the soft tissue attached to the tooth, and that this interproximal papilla belongs to the tooth, and if you don't harm it, even if the interproximal bone is not there, you can maintain it. Now, when you look at two adjacent implants, this development is different, because the papilla between the two implants is restored prosthetically. It's not a real papilla, it's just a piece of tissue which is above the bone. And when we look at alternative, and we can alternate pontics with implants, and Team Atlanta published on that very deeply, that's a different situation. Now, how can we develop in late implant placement or delayed implant placement and restoration this kind of implants? Now, when we look, I was going to meetings and everybody told me to under contour the facial aspect of the abutment. Is that true? That's true if you take frontal pictures. And what is happening is that this permits a very good aspect from the front. We have implants which have a very strong platform switching, conical connection. That's when we have a very good aspect from the buccal. But when we take a lateral view, what we see that there we produce a concavity of soft tissue. And if the soft tissue is slightly collapsing, it doesn't reflect light. Concavities don't reflect light. Convexities do. And that's why we have a different dark aspect. Now, when we look at convex emergence profile, we have the problem that this will provoke instant recessions. And we want to under contour that. We know from orthodontics, Maurice talked about it. You have the implant moved palatal or the teeth moved palatal, the soft tissue will creep down. Now, the big advantage is it looks like a root, but we have a recession. And in the past, we used to match the implants to the root of the tooth, and that provoked also a lot of complications. So that gives us an instant recession. Here you can see darker light, concave abutment, good bone, and the soft tissue collapses. The question is, concave is good, but how much? And that's why we made a study to see what is the difference in the prosthetics. You can see here a convex emergence profile at the implant placed more palatal, which gives the root shape and still doesn't provoke recession. Is that true long term? So we did a publication in IJPRD. We wanted to see what's happening. When can we do a under contour emergence profile? When should it be straight? And when should it be convex? And this is depending on the implant position. When we have implants which are placed more palatally, we prefer a convex emergence profile to have a good appearance. Some examples. So what's happening here that we have an implant placed in the incisal edge position. If the implant is placed in the incisal edge position or more buccal than that, we prefer a concave emergence profile. If the implant is placed between the cingulum position, very good work was published by Buckley in 2015, 2016 about the soft tissue thickness depending on the implant positioning, then the emergence profile buccally should be straight. And this is from a publication we did more than 13 years ago. I will see this case we took out where we didn't under contour and still have a good aspect. However, most of the implants we are placing more palatal in the extraction socket. And having a concave emergence profile or too concave, which doesn't stay in some borders, that will give us a collapse or a concavity of soft tissue. Here we see a convex emergence profile, not under contoured, but followed some rules or some borders. And when we look at the cases from the study, and here are 10 examples, that implants are placed in different positions. Some would say the first implant is too buccal. Yes, but we can correct it prosthetically. Too buccal is slightly more buccally than the incisal line. And we will look, is connective tissue graft needed for implant placement? I disagree totally. Because if the implant is placed in the cingulum position, according to the new research, we see we have enough soft tissue. There's a lot of publication, immediate implant with connective tissue graft. Yes, but depends on the implant position and angulation. Now this playing with the emergence profile, and the first paper we published in the first edition of Cosmetic Dentistry in 2001, or 2004, excuse me, all this is done to maintain the gingival margin long term. So we are looking at the implant positioning, developing the emergence profile, and then the aim is to maintain this gingival margin. Now what do we do? See, we have in the same patient the two central incisors where long-term we have a convex and a concave emergence profile which can maintain the same level of gingival margin, alternating the buccal emergence profile of the subgingival prosthetic elements. And when we know today, we know that implant positioning is also influencing the mid-facial soft tissue. And mid-facial gives us more problems today in single tooth environment than multiple adjacent implant. And we know what's the papilla and how that one is developed from the literature. Now let's see how we really do it in our office. Now we realize that delayed implant placement according to the Rook has 3 times more recession. So when we look at papilla positioning of the contact point, we are looking now at choose paper, because what we did, we knew Tarnow's rule, but we actually in the lab never cut the cast to tell the lab technician, hey, the interproximal bone is here. So it was a rule which we knew, but it was more difficult to improve in your lab. But this new publication, or is not so new by Chu, which shows that the papilla is 40% of the crown length. That's very applicable, and in implants, if we go from 40 to 30%, that helps us position interproximally where the papilla is going to be. Now, before the digital times, this is how we used to develop the emergence profile, especially in cases of delayed implant placement. The first picture is a subtraction design. We take the cast and we develop, or the lab technician, following certain rules, where the contact point should be according to Chu's rule, how much midfacial pressure according to our paper, where is the zenith, is using that for developing. Or additive method. You see, when we don't have enough soft tissue, this is what we have to do. We have to add and make the frames. And here today we do that digitally. And we know that if we maintain these frames and we don't cross them, we can still develop the soft tissue management. Now when we look here, which are the elements which we are preparing? It's the zenith of the future crown, the gingival margin contour, the distal pressure, the mesial pressure, and the gingival margin contour, which is going to be an overlap. And this is what we do. See, in these cases, to give you an example, this is a case published in 2004, and that's what you see, the older pictures. We created the frame where we have to stay within. We knew where to position the contact point and how much pressure should be on that contact point. This is an additive method. We put here composite to see what's the frame. My abutment can be concave, straight, or convex, or under contour, as long as it doesn't cross these borders which we are creating in the lab. So you can see this is what we used to do in the past. Today we do all that digital, and I will share with you. When we go from single to multiple, it's different. So we have subtraction and we have additive methods for creating this kind of design. And today that's the way we do it. We can do all that and then develop this design. So see, I'm positioning my contact points according to Chu's paper. We don't use that 5mm rules. And then we connect the abutment emergence point with the contact points of the future crown. If you follow this design, how much pressure you're going to have interproximally? Where is the future contact point to be? How is the soft tissue predictable grow in the interproximal space? You can avoid many times using temporary crowns. So by using this design, what we do, we don't use so much temporary crowns anymore. We almost eliminated them because we know biologically how much soft tissue will grow interproximally. How is the gingival margin be prepared? And when we go and look, for example, here, this is after a vertical augmentation we did. You can see in the left picture that the abutment was too emerging. Okay, that will lead to compression of the soft tissue. The abutments are there, they are digitally made, but we have to follow another contour. We know this is what we call today the digital induced disease, because it's limited. The computers are limited. I speak with my lab technician and he said, man, I did it with the computer. I said, yeah, but the emergence profile is not good. I took an X-ray with a regular contour healing abutment to show him the difference. The right abutment will compress my soft tissue. According to Linkevicius, we need 2 millimeters. We published a paper with Thomas Linkevicius. We showed that we need 2 millimeters in order to make platform switching work. This is bad. So this will destroy and induce initially bone resorption after this huge vertical augmentation. So digitally induced disease today is a problem. We had to take these CAD-CAM abutments, throw them away, and start again. So I was looking for the analog hero, and I found the analog hero, which was able to give me what I wanted for protection of my soft tissue. Now let's see, thick tissue is different. See, thick tissue, these dentists have patients with thick tissue, which these techniques can work very well. So let me show you one case, step by step. Many years ago, we place an implant, and then the soft tissue contour has to be developed. First, I'm looking at the zenith. This is with the subtraction methods. Then I'm looking what are the borders inside the emergence profile, which my abutment shouldn't cross, and today we do that digitally. I want to show you analog. And then the compression of my crown, because I don't want to have the same emergence profile for an implant like a tooth. That was a big mistake. My lab technician used to cut at the cast and copy the emergence profile. I told him that's wrong. Teeth don't need a buccal plate to survive. Teeth don't need soft tissue to survive. A tooth with a recession can survive. Implants need 2 millimeters of bone. They need 2 millimeters of soft tissue. And prosthetically, you have to allow that to be there. So that's what we do. We give the frames to do that. So in a case like this, after everything is prepared, and this is what we do. You see in the cast picture the soft tissue thickness which will be there. That's the border. And now it's my decision if my abutment is going to be concave, straight, or convex, according to the research we did. And then when we go, this is going to be a concave emergence profile because I placed the implant slightly buccal. This is when we delivered it. And please take a look at the zenith. And then we looked at the follow-up, and you see when we place it in, of course, this is going to shape the zenith, the compression. We're going to have a concavity outside. And from around, with subtraction, when we don't have enough soft tissue and we have additive methods, then it's totally different. So this is what we're doing today prosthetically, analog or digitally. And both of them are limited. So you can see now, this is what's going to happen. Surround emergence profile, we have the concavity on the buccal side under the gingival margin. And then you can see according to the implant position. And this is very key, that prosthetically implant positioning is very important. If you look, in many cases, placing implant in the single loom position makes a big difference. And then this is, we're going to go and follow up these cases. Here you can see from this distal image how the concavity on the buccal part is going to, okay, this is the laser, right? How the concavity on the buccal part, here created by my lab technician, okay, and the zenith, the compression. So we are looking three-dimensionally. And then when we compare that over time, what we need that? Why we need more space? Because we know that the blood supply from the periodontal ligament, which is inside the sulcus, will disappear. We know that the bundle bone is also getting blood supply. That will disappear, but what we need here is thickness. And these implants have to happen laser lock. They have laser lock, and the soft tissue will attach to the abutment or to the implant, can protect, but also the thickness of the tissue plays a major role. And this is what we want to do. Now let's see how we're moving now. So we look 1 year follow-up. You see this is the gingival contour, which we created in delayed implant placement. And when we look at the literature, we wanted to see, can we improve? Is it still 2.5 to 3 times more recession in these cases? And you see the implant has thicker soft tissue than the tooth. The emergence profile of the implant has nothing to do with the emergence profile of the analog natural tooth, because biologically, long-term, we need more. And when we look at the follow-up, you can see now here, this is the 1 year follow-up. Now we have, I will show you, up to 15 years follow-up. Okay, now let's move to the more difficult cases. Multiple implant placement, what we have to do? In these cases, you cannot maintain. We have to create the base for that. Now, when we look here, now, this is a very interesting case. Why? We have 6, 8, 13, and 17 years post-op. So let's see what happened in 17 years. I was 12 when I placed these implants, right, Marcelo? Remember, Jack knows. So, look, here we had to recreate. I was afraid of immediate loading. So now this is recreated. So what's happening? 6 years follow-up. So look at the gingival margin. The literature tells me this should go away. No, the tooth will go away because I created that frame. Now we look, 8 years follow-up. Not bad. Then we look 13 years. What happens after 13 years? Recession on the neighboring teeth, Here we have recession on the tooth, but the implant still looks good. And this is because we created that frame. We removed the pros to measure what happened. How much space did we create here, and how is the gingival margin maintained? Now, after 17 years, you can see now the natural tooth is longer. We have a passive eruption. You have recession on, but look after 17 years, which is the best? Still the implant. Because after 17 years, creating this environment gives me the opportunity, subtractive or additive. Now let's go and see in multiple cases. This is a lady with a high smile line, which had a problem. She missed the second lateral on the left side. I'm not saying numbers because I get confused with the American and the European numbers. We had to shift the midline. She had a recession. And we have to correct all that. So see, we place an implant. And I learned from Maurice and from Team Atlanta that the interproximal bone here is key. So as I have a position at Penn, at the endo department, I spoke with the guys and they said, my God, this is an internal resorption. You think we can save this tooth? I said, no, you have to, because I need this interproximal bone for this lady. So I sent her to Penn Endo, and Frankie Maggiore is trying to do the endo. What do you see? This implant, this two buccal, we can still prosthetically correct. And two buccal today is not such a big problem, but two bulky prosthetic elements are a problem. So this is a problem, and here, this is what I got from the lab. So I had to make corrections of the emergence profile. Contact points positioned according to Chu. If you look at biometric measurements, this tooth has to overlap so we can change the midline positioning. And that's what we do, see? Before, after, overcompensating, implant positioning, and creating the space for the emergence profile. The endo was amazing, okay? Penn Endo is amazing. This is Frankie Maggiore. You see, they saved internal resorption. For me, the interproximal height of bone was maintained. And then we could go ahead and treat this patient prosthetically. Now, what we do prosthetically here, this is what I got from the lab. What most of the people do, and you raise your hand if you do the same, you take an impression, you send it to the lab and say, do it for me. And then when it gets back, you just put it in. But this shouldn't it the way it be. Look, here, this is what I got from the lab. They want to fill the space. The contact point is where it is. We can still have the soft tissue growth if we position at 30%. We provoke a recession. But look what happens. After I change everything in the lab, okay, sorry for that. We change everything in the lab, we can put it back, see? Then the soft tissue grows in, the midline is changed, and now we have to see how this will be delivered. The day of delivery, the patient wasn't happy because the papilla wasn't there. So we took care of the recession, we took care of the emergence profile, we shifted the midline, but we made a video, and I said, it's gonna come back. Doctor, are you sure? Absolutely. Why? Because we know where to position the contact point. This is what's happening. I have the interproximal bone, the endo went well, and now the soft tissue will grow back and fill that space. See? This is what I got, and this is what I have now. Just prosthetic contouring in delayed implant placement. Immediate is easy, but delayed is a little bit difficult. And then a year passed away, the snow came to my office, and this is how she's now. And not only that we changed the midline, she was missing a lateral, but we took care of the recession with implant positioning. We put it to the interproximal bone, and the papilla came back, but we knew how to create those pressures. Now let's move to multiple implants. You can see multiple implants according to a publication we did also 10 years ago. The soft tissue management makes sense when you have the interproximal bone. So in these cases, this is what we have to create the soft tissue on top of it. Because we know when we have multiple adjacent implants, this soft tissue needs bone underneath. And in this multiple implant cases, we have to create the bony frame underneath. And if time allows, I will share with you how we do creation of these multiple cases. Now let's go back. So you see, additive frame. This is the frame for my soft tissue. I have to stay within these borders. And if I do that in a delayed implant placement, this is a patient we had a denture, this is what I can get. Now, these pictures are very old. I'm showing this from 2001. Now it's 17-year follow-up. Why is this so amazing? Because where I created my environment and the implants were integrated, my architecture of the soft tissue is very good. I can have 2 implants aligned at the same level. Where I perform the sinus graft and I have to lay them late, you can see that the soft tissue is not growing. Now we can follow these cases now 17 to 18 years by framing and allowing this under the soft tissue under the gingival margin to be created. 2001. So let's see on the other side. Other side the same, where we create the soft tissue environment, we position the pressure, we look at the zenith of the teeth, and where we don't load them, there is no new architecture of the soft tissue. And when we look how these cases develop over time, we can see that even in cases of multiple implant placement, we can create an illusion, because this is an illusion of a soft tissue design around multiple implants. Now, 17 years after, of course, we have some recession. Nothing works perfectly. So, you know, I was with Dennis Tarno, he told me, you have to write that, no prosthetic scaffold, no papilla. But how is the prosthetic scaffold? We know how the prosthetic scaffold will be, because there is a difference, and that's the prosthetic part. This is what we look at, subtraction and development of the emergence profile, and addition of the development of the emergence profile. See, all late loading. So development of soft tissue after dentures. Now, look another case from the same period, 2001. This is how I did my surgical template with gutta-percha. You know, it's a little bit primitive, but look what we did. We knew from the literature how much time to wait, how to develop that. You know, I used to lecture about this topic, then I didn't lecture for 10 years. I started lecturing only about flaps. Now I go back and I look at these cases after 10 years. We used to place a lot of implants. I was young, I needed a new car, so I placed a lot of implants back then, right, Maurice? So the papilla is reforming after 8 weeks. You can see here we have this illusion, old pictures. But when we look at the follow-up, what we can create, this is what we can create for patients which used to wear dentures, right? Recreating. This is a FP1 case according to Misch. This is a SS case. So this is what we can create. Now when we look, how is that? It's all done by this subtraction or additional framing. Now when we look, this was 1 year, and then we look a couple of years after, this is the frame. It's not perfect, but you know, we have the experience of 17, 18 years. And I'm really happy that I did those documentations in those years, and I used to speak about these cases, but now I'm going back. So what we do the soft tissue development using prosthetic components for the subgingival emergence profile, for single implants and for multiple implants. Still, if you go in the literature, you see that recession around implants is a problem. Is this different? Can we solve this problem? Because when we look in the literature, this is a little bit different. So I want to share with you how we treat those cases and how we identify which is the real reason. Implant positioning for me is one of the reasons, and not so much buccal palatal positioning, but mostly angulation. Now when we look, this is a study which was done by University of Michigan. We wanted to see how many implants placed in prosthetic position, so we can have a good and pleasing aesthetic result, perforate the buccal plate. 20% of all the implants placed in the prosthetic position, we talk now prosthetically, perforate the buccal plate. Another 20% leave less bone than 1 millimeter buccally, which have late complications. And we want to see what's happening, because we have different scenarios. There is one scenario where you can place your implant, and with an angled abutment of 15 degrees, you can correct that position. Then you have other situations where you can place the implant slightly to the palate. That's also a good situation. But you have situations where if you follow the bone, you will have tremendous problems. This is an angle class 2, subclass 2, okay, prosthetic angulation. Now, when you extract the tooth and you only have your CBCT and you're going to follow the bone, that's another digital induced disease, like others. And what you can see here, this is a situation where we have often. So let's share a case. See, this is a case with a deep bite. Now, from a prosthetic point of view, I have to place the implant outside the bone. I used to say a couple of months ago, don't place the implant in the bone, don't look for primer stability, don't imitate the emergence profile. And people said, now he's really nuts, because that's what we do. We place the implants more posterior, we look for primer stability, and we place it in the bone. But when you have this prosthetic classification, deep bite, the column angle, that's the angle between the crown and the root, is very different. So we have to place the implant here, or create a bone around it. See, this is the difference between following the bone or placing the implant in the prosthetic position. This is an extreme case. Now, how many cases we have like that? 10, 15%. That's a lot. That means 10, 15% of failures. So what can we do? People ask me, Marius, what should I do in this case? I say, a bridge. Okay? Right? Or you have to graft it in such a way, like we do here, papilla-based incision, graft the procedure, suture it, and then what's very important, this is prosthetically placed implant. And you have to be aware ahead of time, because if you want to have soft tissue development prosthetically, your implant has to be outside the envelope of bone. And the study we did at University of Michigan showed that 20% perforate the buccal plate if they are placed position prosthetically. Connective tissue doesn't help. Angulation helps. Now let's see if it's bigger, and then you can see here, even if you have a deep bite, we can maintain, you can maintain the soft tissue. Here, this is the framing, subtraction, compression, maintaining the zenith, and then avoiding recession of the soft tissue. And this is what we get. So see, we went here. But what about if soft tissue is thin? This dentist asked me, hey, Marius, I think twice, but my patients have thin tissue. Thin tissue is another problem, which we will see how we solve that one. Now, sometimes we have to place the implants like this, many times. My friend Scott Gans calls this air integration, right? Because sometimes they do integrate in air. So we have to think about prosthetically, how do we get there? And in this case, I don't want to talk about grafting. I told you usually this is my topic, but now I'm talking about pros. We can create this bone, okay? This is just mixing allograft with xenograft, but now my bone, and this is the histology, now my bone is prosthetically where I need it prosthetically. It's exactly here. And now my prosthetic soft tissue development is easy. But vertically, I need more bone vertically to create the interproximal bone. And what I like this compared with blocks is that we have a fantastic blood supply. Now, what did we learn? The interproximal height of bone is key. So we overgrafted vertically to be able to have the support of the soft tissue. And now we can create that soft tissue frame, which we were talking about. And when we look, this is what we do. And this is when we finished. You know, she lost her teeth in an accident, and this is when we finished the case. And she was very, very happy. You can see here, again, a strip. The free gingival graft is the only thing which we had to restore after, to restore the depth of the vestibulum. Now, thin biotype. I'm going to go fast now. Thin biotype is a problem, because the papillas are long, okay, very long. And do we need soft tissue graft? No. Prosthetic is enough. But what we do here, we're going to do a papilla boost flap. I missed an L here, sorry. What are we going to do? We're going to increase the thickness of the papilla in patients with the thin biotype. Graft, and then develop the emergence profile. So you can see here we're doing a bevel, or our incision following to, the technique of Giovanni Zucchelli, which he's using in Italy. We're going to take the tooth out, place an implant, do the grafting, and then increase the thickness of the papilla. This is not a coronally advanced flap for grafting. This is just so we can play it later on with the soft tissue. So see, we are boosting the thickness of the interproximal papilla, and then creating that environment prosthetically with the good compression of the interproximal soft tissue will make these cases look good. So you can see, I choose for you just a high smile case, the patients which have a gummy smile. What happened, I made a Maryland bridge. I told you this is all late. You know, I try to avoid immediate restoration because that's easy and looks good and predictable. We want to make it delayed so we can see we have the same problem. And the Maryland bridge came loose. She went to a colleague and she put a lot of composite and the papilla was gone. But by thickening, by boosting this soft tissue, this will come back. So now we can play a little bit with the soft tissue. In this case, I told you we reduced the temporary crowns. In this case, we are using temporary crowns because we have a thin biotype patients. And what we are doing now, we are creating this soft tissue environment. See, the papilla here was gone. Here, it's very long, more than 50% of the emergence of the crown length. Then we can create, without soft tissue surgery, a good environment for the soft tissue by using these developments. You can see at the time of, this is the final crown trying. We are just reducing. We expect a little bit of coronal creeping of the soft tissue. And when we have the final aspect, we can go ahead and restore that. So you see, this is how we started. See, papilla pressure distally. What happened? We have a broad contact point. And this papilla regrew to be very broad. It was gone. Then we have the zenith of the crown. We know how much pressure we're going to have that. The papilla pressure mesially and the gingival contour. We have the frame for the abutment design. So we know if you go straight, concave or convex. But here, this part of the soft tissue, after the papilla boost technique, see, this part of the soft tissue is very, very broad. We have a broad contact point that this part is just regenerated after we created the prosthetic soft tissue environment. And we can look here now at the distal part, we has a broader contact point, and when we look at the mesial part. And here, by the right emergence profile design, you can see we went for a patient with a thin biotype, with thin tissue, to a very thick tissue outcome by creating that prosthetic frame for delayed implant placing cases. Now, when we look at this case, this is when 6 months after delivery, and now we looked another 1.5 years. So this is very important because this helps also patients which have a very thin biotype and thin tissue. And when we look, we can see that the soft tissue came down more coronally. This was creating the housing. This is the implant in position. And we could increase the soft tissue outcome just by framing. See Maurice coming up, so the conclusions just showed up. Implant positioning protects bones, you know. I always wait them to come and then my slide goes up. Emergence profile protects the tissue recession, and you can create today by subtraction, by additive methods, creating the frame, and your emergence profile can be convex, concave, straight, the pressure according to you, to have a very good outcome. And when you don't have the osseous base, you have to create that osseous base, and when you need the interproximal bone to maintain that soft tissue in multiple implants, you can create those. Thanks very much for having me here.